we're going to do cardiac tumors and masses today. Uh, today I was reading uh, an echo, and there was something in the right atrium, and so I had to make a decision. What is this? Um, of course, I looked through the history of the patient, and didn't mention that there was any pacemaker or any intravenous catheter. So, of course, the the structure, the mass looked like it extend into the RV. So, my impression was it was a pacemaker lead. Um, so you're gonna come across objects in the heart, so-called masses in the heart, and you will have to come up with a reasonable diagnosis as to what it is. So we're gonna look at a number of uh, masses and tumors, and hopefully we'll help you to make an assessment. So when we talk, well, what we're going to do, we're going to look at primary and secondary tumors, benign and malignant. And when we talk about primary tumors, that means it arises from the heart. It That's where it initially uh, starts from, and then secondary tumors arise from elsewhere and invade the heart, so to speak, or can metastasize to the heart if it's a malignant lesion. And then, very important, we're going to look at normal cardiac structures that mimic masses and tumors. So this is very important because a lot of time we'll see the gestation valve, and it looks like a thrombus. Okay. Again, please mute your mic. Mute your mic. All right. And also you're going to see a lot of clots, thrombus, and remember that you're going to see thrombus in at least two situations. Patient with atrial fibrillation, if the duration is more than 48 hours, you'll see thrombus are clots in the left atrial appendage. Also, patients with very severe depressed LV systolic function, you can see thrombus clots in the LV apex. So those are the two most common scenarios where you're going to get thrombus. So let's look at some primary. So again, when we say primary tumors, these tumors arise from the heart, and then secondary tumors metastasize to the heart. Primary tumors are relatively rare. It's very, you're not going to see a lot of primary tumors. It's more common for you to see a metastatic lesion. So that's much more common. However, there are some primary tumors that you have to know, and the most common primary tumor of the heart is what we call myxoma. Okay, so it's the most common primary tumor of the heart. Myxoma is usually benign, and of course, when we talk about benign, it's non-cancerous, and then malignant, that means it's cancerous. So myxoma, the most common primary tumor. The most common location for the myxoma is in the left atrium. It is usually attached to the atrial septum via a stalk. Okay, so it is usually pedunculated. When we say pedunculated, that means attached to usually the atrial septum via a stalk. In the vicinity of the fossa ovalis. Okay, that's the usual location. But you can have myxomas anywhere. Okay, but that's the most common location. All right. What are some of the clinical manifestations of myxoma? So I had the privilege of seeing a myxoma. Uh, the patient presented with a stroke, a CVA. So we the patient presented with a CVA. We did a transthoracic echo, and we saw this mass in the left atrium. And of course, our first impression was a myxoma. We did a transesophageal echo, and that confirms it. So, in terms of clinical presentations, CVA and the mechanism there is usually embolization, because on these myxomas, you can have yeah. So Pam was the technician involved in that case. So okay, so these myxomas, you can have clot forming on top of them, and it can break off and embolize, or a piece of the myxoma itself can break off and embolize. Okay, so embolization, that is uh, a piece of the myxoma breaking off and traveling distally. Okay, patient can present with weight loss, cachexia, syncope, because the myxoma acts like a ball valve, and it's in the left atrium. When the mitral valve opens, the myxoma is pushed into the open mitral valve, trying to get out of the left atrium. And as a result, it's going to block the blood flow going from the left atrium to the LV. So the patient becomes hypotensive and passes out, syncope. They can die, because this uh, mass is obstructing blood flow, so they can die, sudden cardiac death. As well as it could be the patient could be completely asymptomatic. They come to the echo lab for something pre-op evaluation, and they're found to have a myxoma. So, you have to go through your routine study, and you'll pick up a lot of stuff. So any exam you do it with echo, you're gonna see something looking like this. This is a M mode. Okay, and so on top you have the two-dimensional uh, echo, and then the cursor which crosses through the varying structures. The first, the chest wall, the RV wall, the RV cavity, the septum, the LV cavity, and the mitral valve. And if you look closely here, you see a mass. There's a mass right here. And when you do your M mode, passing through the same structures: the chest wall, the RV cavity, the septum, and this is the LV cavity with the mitral valve. In diastole, when the mitral valve opens, you can see this mass. So this is the myxoma. So that's classic M mode feature of myxoma. And as mentioned previously, you've got all exams, they're going to give you this and ask you for the differential diagnosis. All right, so this is actually our case. This is our case. So we did the transthoracic echo, and we saw this mass, and right away we put two and two together, and it was a myxoma, because it's located in the left atrium. We didn't see the attachment right here, but the consistency was suggestive of myxoma. All right, and again, in four-chamber view, you can see the attachment. It's attached to the atrial septum via a stalk in the vicinity of the fossa ovalis. Okay. All right, so that's the most common primary tumor. It arises from the heart. Now, we're staying with benign tumors. The next tumor we're going to talk about is the fibroma. And as mentioned before, primary tumors are rare except for the myxoma. The thing about fibroma, however, it occurs primarily in children. So if you have a case with a 10-year-old and they show you a mass in the vicinity of the interventricular septum, or the left ventricular free wall, you want to think in terms of a fibroma. Okay, so the things that you have to remember, primarily in children, and it's in the LV, either on the interventricular septum or the free wall in the LV. So fibroma, all right? Children, usually in the LV, the septum. The next important tumor is the rhabdomyoma. And again, you're going to get this because this is sort of classic tumor. It's a benign tumor, non-cancerous. Rhabdomyoma. When we talk about rhabdo, we talk about it's a skeletal muscle, okay? And then rhabdo means a skeletal, and a myoma muscle. So it's a skeletal muscle tumor. So the association with rhabdomyoma, again, it's the most common primary tumor in kids, pediatric tumor of the heart. So it's the most common primary tumor in kids. But the association between the association with rhabdomyoma and tuberous sclerosis, they're gonna make that, you have to make that connection. So tuberous sclerosis, these are kids probably mild mental impairment, and they have these numerous tumorous lesions usually on the face. Okay, so if they talk, and some of these kids will have seizures and stuff like that. So if they mention anything about tuberous sclerosis and it's in a kid, the tumor is usually a rhabdomyoma. The thing about these tumors, they may undergo spontaneous regression, that they just resolve, they just go away. The location for the rhabdomyoma is in the RV, so in sometime in the right ventricular flow tract, in that vicinity. So remember that the fibroma are kids, usually in the LV, the septum. Okay, that's the fibroma. But the rhabdomyoma, kids again, but it's associated with tuberous sclerosis. I may get spontaneous regression, RV. You have to know everything about myxoma because you're definitely going to get that. You may get something like this, but you're definitely going to get myxoma. The next benign tumor is the papillary fibroelastoma, very common. So if you see these little structures, and usually on the aortic valve, you can get it on the pulmonic valve, mitral valve as well. Okay, papillary fibroelastoma. So it's the third most common primary tumor of the heart. Okay, papillary fibroelastoma. So you have to definitely know what it looks like, and these are usually incidental findings. It typically involves one of the valves, the heart valves, usually the aortic, but it can occur in the mitral, tricuspid, and pulmonic valve. You may get embolic phenomenon, so you might have clots forming on top of it, break off, travel to the brain, and the patient may present with a CVA. Okay, but more common, it's an incidental finding. So your papillary fibroelastoma looks like this. Is a transesophageal echo, and you can see this little tumor on one of the aortic valve. So the papillary fibroelastoma. So benign, third most common benign tumor. So, and again, if you look here, you can see a little tumor, a little structure, a little mass, and the aortic valve. So again, your transesophageal echo. This is your interatrial septum. The cusp adjacent to the interatrial septum is your non-coronary. Okay, so your non-coronary cusp is right there. This is the left, and then this is the right here. So this structure looks like it's on the left. Okay, well, not really. So this is your interatrial septum. You get your non-coronary, the left and the right. So it's probably more in the right. Okay. Okay. So, and you can see it in this view as well. Okay. So, papillary fibroelastoma, small, small mass. So it's not very large. So you should be able to identify. Usually occur on one of the valves. Most commonly, the aortic. So there's one here, the right ventral flow tract in the pulmonic valve. Okay, so there's one right there, papillary fibroelastoma. So it's a benign tumor. All right, so those are the benign tumors. Now, malignant tumors, the primary malignant tumors, that is cancers occurring inside the heart, is relatively rare, very rare, as a matter of fact. But some of the primary malignant tumors in the heart is angiosarcoma. When we say angio, we mean blood vessels. Sarcoma is a malignant tumor. And then rhabdomyosarcoma, so skeletal muscle cancer, myxo or sarcoma, osteosarcoma, osteous bone, fibrosarcoma, synovial sarcoma. So these are malignant tumors. And then you can get secondary tumors, that is metastatic lesions. So if you have a breast cancer, a lung cancer, kidney or liver, these tumors can metastasize to the heart. And so the secondary tumors are more common than the primary tumor, malignant tumors, that is. You can get lymphoma, metastasizing melanoma, and osteogenic sarcoma. So there's a tumor. All right, so masses that you can get into the right atrium, and of course, mass that mimics tumors and stuff like that, is the eustachian valve. So you must remember where the eustachian valve is located. So the eustachian valve was the embryonic inferior vena cava valve. So it's a remnant of the valve of the inferior vena cava, okay? And it lies at the junction of the inferior vena cava and the right atrium. And you can see that remnant in adults very, very often. It looks like something just flapping in the right atrium. In fetal life, the eustachian valve directs oxygenated blood from the right atrium into the left atrium. So remember that in utero, the lungs, the lungs of the developing fetus is not functional, so to speak. So oxygenated blood from the mother gets to the baby via the placenta, but the oxygenated blood travels first to the right atrium. So this eustachian valve directs the blood through the fossa ovalis into the left atrium, and then oxygenated blood travels from the left atrium into the left ventricle, and then out of the left ventricle via the aortic valves. Okay, so that's the function of the eustachian valve in utero, but it persists. Okay, you can visualize the eustachian valve best the apical 4 or the subcostal view. So these are the views that will allow you to look at the eustachian valve best. the apical four-chamber view and the subcostal view. Also, if you do a transesophageal echo, you can the bicaval view will show it. So a lot of you guys, so this is an apical four-chamber view. A lot of you guys have seen this in the right atrium. You have this thread-like structure, and we call it, some of us misdiagnose it as thrombus and give it all sort of stuff, give it all sort of name. But the thing about it, it tends to be flopping, moving. It doesn't have the consistency of thrombus. So it's usually a Eustachian valve. Okay, and that's a fair game in exam as well. So coming back to my case today, I saw during the echo, nothing in the history to suggest that the patient had a catheter, a pacemaker, anything. But however, the structure, the mass was in the right atrium and the ventricle, and in some views it looked like it's a pacemaker lead. So I made a call, pacemaker lead. But of course, central catheters. Okay, so we'll put these central catheters and leave the tip into the right atrium. So be aware of that. Thrombus, blood clots, can also form in the right atrium, and you can get vegetation, infected materials in the tricuspid valve, or if you have, usually in the tricuspid valve. So these are some of the more common masses that. So this is yes. So Pam is always very interested in Eustachian valves. So if she sees one, she will get excited about it. All right. So this is your apical four-chamber view, and you see something here in the RV, and you may or may not see something in the RA. But I mean, you usually see. So if you see something look like that, and then you see something in RA, it's more like a pacemaker lead. So you make the call. Okay. But sometimes you see stuff looking like this. This is this patient actually have a pacemaker lead from the right atrium, right ventricle, and they actually have the huge vegetation on the pacemaker lead. Okay, this is a huge vegetation. So when the heart contracts, you can see how the mass moves. You can see the consistency of it, and then you make a call. So this patient may present with fever, chills, generalized malaise, typical infectious symptoms. So, and then if you see something looking like this, then you make your call vegetation. All right. So that's the right atrium. What about the left atrium? At the onset of the lecture, we talk about, atrial fibrillation and clots forming in the left atrial appendage. So on the transthoracic echo, you're not going to see the left atrial appendage, but if the clot is large enough, it can extend into the left atrium and you can see it. Okay? So thrombus in left atrial appendage, usually transesophageal echo. But if the clot is large enough, it can protrude into the left atrium. And then atrial fibrillation patients, this is where clot lives in atrial fibrillation patients. So patients with atrial fibrillation, sometimes it takes as short a period as 48 hours for clot to form. So clot forms in the left atrial appendage, or clot can break off and embolize, travel distally, and patient will present with strokes, infarcted bowels, and stuff like that. And it's fairly common in patients with mitral stenosis as well. So your patient with mitral stenosis and atrial fibrillation, this is a dangerous combination because they are almost always going to form clots in the left atrial appendage. So if you suspect left atrial appendage thrombus, clots, you have to do your transesophageal echo. So remember, your transthoracic is not going to allow you to see the left atrial appendage. So, but sometimes it can extend into the left atrium. Okay, so there's and you can see this patient actually had a clot. So this is a apical fold showing a large mobile. So this is a clot also here, and then there's a left atrial appendage thrombus which protrudes into the left atrium. So but if you're accustomed to doing your echo in a routine fashion, you'll pick up all these things. The other thing we're going to talk about is your lipomatous hypertrophy of the atrial septum. You're not going to see a lot of this, but it's going to appear in all exams. It's a very testable pathology, so they usually put it. All right, you're not going to see it. So the classic features of your lipomatous hypertrophy of the atrial septum, you get a dumbbell appearance of the atrial septum. The fossa ovalis is spare. So you'll get swelling on either side of the fossa ovalis, okay? Usually the septal thickness is 15 millimeters or greater. So it looks somewhat like this. So when you look, this is the fossa ovalis. Above it, the atrial septum swells up. Below it, the atrial septum swells up. So that's why it says, it has a dumbbell appearance. The fossa ovalis is not involved in the process. So this is a benign condition. It's when we say lipomatous, mean fatty tumor. So you get the fatty tumor here, fatty tumor. So it's I guess because it's very classic, it looks very distinctive, they bring it on all exam. Okay. All right, so let's move now to the ventricles, and let's look at the left ventricle. So again, you can have blood clots in the LV apex. As a matter of fact, you can get it anywhere in the LV. One of the most common location site is the apex of the LV, especially in patients with very depressed LV systolic function. So clot in the LV, most commonly in the apex. So if the patients have a heart attack involving the LAD and the apex is not moving. So remember, blood is only going to clot in areas of the heart where there is no movement. So when you have a heart attack and that muscle is not thickening, it's not moving, the blood will stagnate and clot. So patients with ejection fraction 5 and 15%, be aware. Okay, these clots can break off and embolize, travel distally. A patient can present with strokes, infarcted bowels, and embolization in the lower extremities as well. You can use your color flow. Again, sometimes shadowing, you can get a heart effect in the apex, but if you move your transducer around, you use color flow and you use contrast. So contrast will confirm the diagnosis because it's a space occupying lesion. So the contrast cannot get into that space. So when you do your contrast, you'll see your contrast all around this mass because it's a space occupying lesion and the contrast cannot get into that space. All right, so apical thrombus. Okay, so this is, and of course, if it's classic, you don't have to do your contrast. Okay, but sometimes it's not that classic, and you have to do your contrast studies. Okay. All right. So that is your. The other thing which is very testable is your hypereosinophilic cardiomyopathy. Okay. Hypereosinophilic cardiomyopathy. And the reason for that is because these patients also present with apical thrombus. Okay. But if you're doing an exam and they talk about the patient may have a parasitic infection and they talk about elevated eosinophil, you just close your eye and you take hypereosinophilic cardiomyopathy. Okay? All right. So when you do your white blood cell count, if the eosinophil count is greater than 1500 per mLs, then it's suggestive. The difference, though, is that these patients usually have normal LV systolic function. Remember what I said? You usually get blood clots in area of the heart that is not moving. So your hypereosinophilic cardiomyopathy is different. These patients have normal LV systolic function. So the patient who will have a normal LV systolic function, they're going to talk about parasitic infection. They're going to talk about the elevated eosinophil count. And especially if they give you a count greater than 1500. Okay, it's usually in the apex, so apical thrombus. Patients sometimes have pericardial effusion. They may have thromboembolic phenomenon. And again, you use contrast agent to make the diagnosis. So you get an apical thrombus in someone with a normal ejection fraction. The heart is contracting normal. Okay, parasitic infection, elevated eosinophil count. The only thing is your hypereosinophilic cardiomyopathy. All right, so we're gonna stop here. Those are some of the more common uh, tumors and masses. Of course, there are others, but you know, when you do your echo day in day out, those are the ones that you're gonna come across. Um, so you need to know the common ones. Myxoma, you have to know that inside out. For kids, you have to know that, your rhabdomyoma is associated with tuberous sclerosis. So they're gonna make that association, and you need to come up with the correct tumor. So that's your rhabdomyoma, and then your fibroma, in kids, usually in the LV, your fibroelastoma, your papillary fibroelastoma, that's usually on the valve, little little tumor-like structure, usually incidental finding. So you have to know that. Uh, know that you can have primary malignant tumors. Those are not very common, so you don't have to memorize that. Secondary tumors, though, be aware of those because the patients commonly have breast, lung, and those type of cancer which can metastasize to the heart. But of course, every day you're gonna see pacemaker leads, so you have to know that's the pacemaker lead. You see catheters in the heart, the eustachian valve. Okay, don't see the eustachian valve and diagnose tumors and stuff like that. So remember the eustachian valve and your lipomatous hypertrophy of the atrial septum. For exams, you're probably you'll never see a case of that, but it's classic, so you'll bring it on the exams. And then patient. The thing about vegetation, the more common presentation of vegetation, patients going to have evidence of infection. Patient, you might have a intravenous drug abuser. There's someone who inject drugs. They usually have right-sided vegetation, usually in tricuspid valve, so you can see that. So, but once you go through your routine and stuff, you won't miss these cases. Okay. And they're real. As I said, we have seen tons of vegetation. We have seen myxomas, a lot of eustachian valve, which mimics all sort of stuff. So